My name is Scott Boliver, and I had laparoscopic Roux-en-Y gastric bypass surgery on May 6th of this year, and I've lost 117 pounds. I've struggled with weight since early childhood, and I've been obese for all my adult life. I'm also an active member of the ObesityHelp California message board. And if you're not on the board, any of the boards, but the California one is particularly active and very supportive, I would really recommend that you get on the message board. It's a great place to find support. We're going to talk a little bit about head hunger. A phenomenon known as head hunger is highly correlated with the loss of food as a coping mechanism. Head hunger can be defined as a compulsion to eat even though there are no physical symptoms of hunger. It's more on an emotional level rather than on a physical level. What is it that makes me want to eat at particular times? Is it the stress? Is it being in a certain place in the house? Is it the television when the television's on? What could you recognize as warning signs that you're going to begin eating when the hunger's not really there and it's not time for you to eat? When does this behavior occur? It's important to answer all these questions so that you can avoid or alter your environment to stop the behavior from occurring at the antecedent level. Next, determine what is maintaining the behavior. What is the function of the behavior? Is it the oral, facial stimulation of putting something in your mouth? Is it the physical feeling of having something in your stomach? Is it replacing something else? You have to find out what it is that the behavior, what function the behavior is serving, so that you can come up with an alternative or replacement behavior. Another thing that could lead up to depression and to anxiety is boundary issues and sabotage. But boundary issues can include intrusions like people telling you that you took the easy way out. Anybody heard that before? Or you shouldn't do this because you're taking the easy way out. Are people asking whether you should be eating something? Are you supposed to be eating that? Are you allowed to have that? Should you have that? I'll heard that one. These types of people who do this constantly violate boundaries and are sometimes known as toxic friends. They may be negative, quick to criticize, and full of unsolicited advice. They can sabotage your resolve by putting temptation in your face or pouting because they can't get together because you have exercise class. They may use psychology as a weapon, analyzing you in a way that makes you feel raw and inferior. How do you handle these toxic friends? Take the direct, assertive approach. Don't be a doormat or a witch. Express your opinions and feelings with clear, calm, rational limits, and be explicit about what you expect. Make sure that they know that you want to stay friends, but that this is an issue that needs to be put behind you. So you really have to take the assertive on this. You're going to have to tell that person, I don't appreciate you telling me that. I know what I should and shouldn't be doing, and I want to stay friends. I want this relationship to maintain, but we need to put this behind us because it can become very toxic for you and could jeopardize your weight loss. Another thing that could lead to depression is repressed or hidden issues that emerge, including various forms of abuse and trauma. It's very common in people who are obese that they have had some sort of trauma or some sort of abuse, not all the time, but it is common. And so those things could start emerging as the pounds start melting away and that defense comes away, because a lot of us use the fat as a way of defending ourselves from something. So it keeps us kind of insulated and surrounded. In a recent research study that was published in the Journal of Obesity Surgery, weight loss candidates, those who were waiting for surgery or looking into surgery, have a lifetime prevalence of 56% to have a mood disorder. So 56% chance that everyone in this room, that 56% of you will have a mood disorder sometime in your lifetime, versus 17% for the general population. So there's a huge difference, big gap there. Anxiety is the most common psychiatric disorder. The lifetime prevalence in the general population is 25%, and in our population, 73%. Again, there's a huge gap, 73% compared to 25%. Anxiety can take on many forms. One form is the panic attack. Raise their hands. A panic attack is a discrete period of intense fear or discomfort in which four or more of the following symptoms develop abruptly and reach a peak within 10 minutes. Heart palpitations, sweating, trembling, shortness of breath, choking, chest pain, nausea, feeling dizzy, derealization or feeling that things are unreal around you, or depersonalization, feeling like you're detached from yourself or outside of yourself, fear of losing control, fear of dying, numbness, or chills and hot flashes. There are many drugs for panic attacks. They're extremely effective. The two of the most popular are Ativan and Xanax. However, they're also very dangerous drugs in some ways because they work so well. They become very psychologically addicting. Agoraphobia. Agoraphobia, most people think of that as it's a fear of going outside or a fear of going out of the home, and it is, but really what the main thing it is it's a fear of being somewhere and having a panic attack and not being able to escape. The fear of the humiliating or embarrassing situation of being in a crowd, being in a line, on a bus, on a train, on an airplane, and having a panic attack in front of all these people. Because the person having the panic attack, people may not know they're having a panic attack, but to them, it feels like everyone is looking at them and they are panicking and they don't know how to escape that, and it becomes a very, very bad situation. In cognitive terms, when dysfunctional thoughts are subjected to rational reflection, one's emotions change. So if you think about it, you may change your emotions because you're going to think, you know what, that person's not really staring at me. They just looked at me, glanced at me, it wasn't a big thing, and you'll feel a little bit better about it. So the crux of cognitive therapy, and what we want to do eventually, is to find out where are these thoughts springing from? Where do they come from? And where they come from is something called core beliefs about ourselves. All through childhood, we're told certain things. Teachers, parents, other people tell us things about ourselves, and we begin to accept those things as true. One of them might be something like, I'm incompetent. And so we learn to believe I'm incompetent, and it colors everything we do. And then once we can get down to those core beliefs and begin to question those, and question those automatic thoughts, we can begin to come up with a more balanced way of thinking, and our emotions can begin to heal. If you're looking for a therapist, there are several ways to find one. We have a lot in the room, and ObesityHelp has a referral as well.